I love a rapid test. All the point of care tools I use at work make my workflow so much smoother. Patients get test results within maybe an hour in a convenient place, such as the clinic, pharmacy, even in their own homes. And then we get to start treatment or management immediately. Essentially, what's not to love? From my personal experience with my patients, rapid flu and strep tests are amazing. But there are drawbacks. So let's break down rapid test pros and cons. I should clarify. Rapid tests and point of care testing are slightly different categories. POC tests are referring to those quick tests you can do at the bedside, such as the beloved iStat tests, which can get you electrolyte results immediately. I use this all the time. Rapid tests represent a broader category. These tests get you results within a few minutes to upwards of an hour, and they range from tests for respiratory infections, antibody tests, pregnancy, urine dipsticks, even metabolic tests. There are so many. First factor to consider is accuracy, the classic sensitivity versus specificity trade-off. Biostat reminder, high sensitivity catches most true positive cases. High specificity rules out diseases and reduces false positives. Clinical judgment has to be used with rapid testing because accuracy can vary widely. With at-home COVID tests, for example, the numbers varied according to the studies, with sensitivities ranging from around 50% to mid-80s, with specificities as high as 99. Rapid diagnostic tests do vary meaningfully in their accuracy, even within the same disease category. Take infectious disease, for example. Rapid strep tests generally show sensitivities in the 80 to 90% range with higher specificity. Rapid flu tests, that reliability really differs on how they're used, with sensitivities ranging between 50 to 70%, but a higher specificity, upwards of 99%, so less false positives. For HIV, the OraQuick in-home test, that's got really high sensitivity and specificity of 92% and 99% respectively. Rapid metabolic tests, such as those testing hemoglobin A1C, a lipid panel, or troponins, those are more of a point of care test to be done in a clinic. And while they're generally pretty accurate, it differs because those tests are measuring a quantity. And the sensitivity and specificity depend on chosen cutoff values, such as 7% for hemoglobin A1C, triglycerides of 170, and so forth. So first line of thought is clinical judgment. And if point of care testing or rapid testing would actually help manage your patient flow and decision making. At-home testing can be tricky because aside from the test itself, there's user error. People need to swab appropriately in their noses or throat. For example, there were scenarios in COVID where viral load would be higher in the throat, but people would swab in their nose and then cases are missed. And then people need to know how to interpret their home test and more importantly, what to do with it. Let's say someone tests negative on day 2 of symptoms and then they go to their office holiday party and then they test positive on day 4. That is potentially a public health problem. Home tests cannot add in all the clinical context needed to interpret results, such as duration, exposure, history. That's where we come in. Aside from clinical guidance, the economics of rapid testing is fascinating. It almost feels like a PhD dissertation I barely understand. The upfront unit cost of a rapid test is almost always lower than lab testing. But think about the total cost per correct diagnosis. In other words, how many false negatives, potential calls, and potentially more expensive confirmatory testing might be needed. Yet on the other hand, rapid testing has a strong potential for lowering downstream costs, such as reducing outbreaks and huge healthcare savings. So this needs to be weighed on a case-by-case basis, thinking about a specific clinic, specific population, and condition being tested. Okay, follow me here. This took some thought, but a general framework might be high pre-test probability and confirmatory result needed, send that to the lab. But moderate pre-test probability, and then there's an immediate treatment or decision plan, you can justify rapid tests in this situation. And then low pretest probability, this becomes consequential with screenings. We're testing asymptomatic individuals without clinical symptoms. These are situations where you don't want a false positive. And this is a recurring source of debate in certain cancer screening programs. This entire concept gained notoriety during the pandemic when rapid antigen testing was used to test asymptomatic travelers. Oh, and for good measure, part of the reason that rapid tests aren't just readily available is because of regulations brought on by the Clinical Laboratory Improvement Amendments, CLIA, which was passed in 1988. The CLIA ensures that tests are accurate, reliable, and timely. That's important. There may be some exceptions for certain bedside tests, such as urinalysis dipsticks. They're basically tiers of regulation from uncomplicated wave tests, such as pregnancy tests, mid tier, such as point of care electrolyte tests, and then there's more complex tests like antigen tests, which require full regulatory oversight. Woo, even though I use them all the time, I have never thought this much about rapid tests as a broad category, but perspective matters, so I want to hear from all of you. I'm curious about all of your thoughts on rapid tests and if they actually help shorten visits. Have you used them to triage care outside of a clinic? If they improve patient satisfaction versus create more liability, confusion, and cost too much? Any specific rapid tests you love? What about ones that you hate? Comment below.